So I'm a neurosurgeon in Coeur d'Alene, Idaho, and I have a hospital practice where I do neurosurgery, brain and spine tumors, traumas, everything that comes our way in neurosurgery. But I'm pretty passionate about my elective practice as well, which is largely a minimally invasive practice, and it's something I've been pushing and pushing and pushing more and more into the outpatient surgery world, and have been successful in doing so. And I've recently incorporated 7D machine vision flash navigation into my surgery center. This past summer, I got the unit, and I'm going to share this with you and why. So why? Why for me is, why 7D with all the other things that we have out there? Well, 7D addresses radiation. There's absolutely no radiation with this flash system. It's a great workflow. It's not expensive. It's a third of the cost of any of the robots out there, and it's very, very, very accurate. It's a new vision for spinal navigation. The way it works, machine vision technology is very advanced, and we're all familiar with it. It's what makes cars work, Tesla cars work. Okay, these cameras are sitting on cars like Teslas, camera-driven cars, and whereas the car knows where it is in the GPS coordinates of the Earth, and these cameras are programmed to identify trees and women pushing strollers and men walking a dog or whatever they can see, bicyclists. You transfer that to the spine, and you can put these same cameras onto the workstation, and they can see the spine, and they can pull out segments that you're interested in whatever picture they take. They're very accurate cameras, and here's how it works. Here, this is the actual machine vision camera here, and it's cleverly mounted on what looks like an operative light, and this operative light is not mounted in your OR, it's on the actual machine. The whole machine just sits in a space right next to me here. It's not a very big thing. This happens to be one of the best OR lights you're going to get to, because the flash navigation that's involved is very bright. So you trade what you're used to hanging over your head for something that's pretty darn efficient. The cameras are sitting here on the inside of the ring here, and then the flash projection occurs from the periphery, all these lights. And when the flash happens, it gets bounced back. You get a million different data points get brought back into the picture, and it's a three-dimensional view that it creates, and you can see this three-dimensional view of the whole area here. But the spine surgeon is capable of honing into what he or she wants to see. So you can pull out L4, L5, C1, C2, whatever part of the spine from occiput to pelvis that you want to see. And because it's three-dimensional, it can pick up little nuances in topography of the surface anatomy of the spine. So it's very important, for example, when you do this, you need a meticulous subperiosteal dissection. You're not going to put a cob in there and scrape away things. You're going to, bovie down, clean, expose, and keep the nuances of the spine intact. This is how it works here. You can see the foot pedal here. It's all surgeon operated. We're going to do exposure, flash it. It's registering right now. Now you're going to touch a few points that you've pre-marked on your preoperative CT. You're going to merge this together, and then you can check the accuracy after the merge goes through to see if you like it, and you'll get some feedback on how much you got, how much accuracy, how much you saw in your with your picture of of the spine that you've taken with the cameras, to know if you've got the right trajectory of your camera. And you can see here it took, in this case, 17 seconds to do. I think really 30 seconds is realistic, and that's about what it takes to do this. If you don't like it, you can redo it. No X-ray. There's a preoperative CT scan that's done, but there's absolutely no X-ray to be used, other than I'll do a localizing X-ray to whatever level I'm going to operate on. Here's a colleague showing you this is everything that you need here. You need this yourself, a surgery tech, and a circulator. There's no reps, there's no entourage, nobody else. And again, the whys. You eliminate radiation, you cut registration time down to a brief half a minute. Your improved accuracy and outcomes, just speaking to what Dr. Foley commented on earlier, what if you bump it? What if it shifts? What if something changes? Not a problem. I'll often even move my fiducial array if I want the trajectory of my screw to be different, reflash, and you have another either full registration taking about 30 seconds, or you can do what's called a flash fix. If you get a little bump in the fiducial array, you can hit a flash fix button, and what it does is this thing has a memory to it. It knows it took that million points of data, and it's stored, and it knows where all those points were. When it senses that the fiducial array has moved any little bit, just a quick flash fix, and it'll re-register everything, and you can check your accuracy and be quite good with that. And reduce costs and increase efficiency. You develop a workflow that's amazing. I mean, for me, this brings the intelligence back to me, the user, takes it away from the machine. For me, it's like having another violin in my symphony. You just use this little pointer or anything that's registered. Your drill can be set up to be a part of the equipment, your pedicle screw system, whatever you're going to use. And it's really, the workflow is incredible, and you decide what it is. You can call an audible if you want to go from a traditional pedicle screw approach to a midline or a cortical screw approach, no problem. If you want to switch from a cervical facet screw to a cervical pedicle screw, not a problem. It's broad clinical utilization. It's good from occiput to pelvis. So since it's picking up off of surface anatomy, it's great for intracranial off the back of the skull or front of the skull, any part of the skull. Occiput down, C1, C2, mid-cervical. You have if you're getting into a very dynamic part of the spine, like the cervical spine, you can do segmental registration of each level, and you can do it pretty quick. So it's not a big process you could either do a block registration if it's a fixed segment, you can do like a L4, 5 together, or you can do each segment by itself and do it more dynamically. The radiation reduction is real, and I don't care what study you choose, you're going to find at least a 90% reduction in radiation, whether it be from a fluoro-based system or a navigation system, and that's big. I mean, I'll tell you, when you bring a new technology into the operating room, often your staff are kind of like, oh my gosh, here we go again, something new, a new learning curve and all that. The learning curve for this, by the way, you become an expert pretty quick. It's you try it first at the booth and at the trade show, and it's kind of intimidating. There's a lot of people around. There's a lot of corporate personnel talking. Then you go to the lab and you do a cadaver, and by your second set of screws, you're having your scrub tech learn how to do it, or your circulator learn how to do it. Then you bring it to your own OR suite where you're comfortable, and it's just another one of your tools. But the reduction in radiation is significant, and that's for everybody in the room. That's for everybody, and they love it, and I love it. That's one of my most favorite things about it. Time and cost savings, this is in seconds. This is average seconds to from setup and registration time, and you can see for CT-based systems, 794 seconds, roughly 13 minutes on average. For the 7D flash navigation system, less than a minute, 41 seconds. It's approved for cranial navigation. I have it in my surgery center. I don't have it at the hospital yet. I'm hoping to do so, but it's approved for cranial spine navigation. I have the open system. I don't have the PERC system. I don't have a 3D imaging in my surgery center, so I do the mini open type work. Why it's ideal for my practice? Well, I've been doing outpatient surgeries, outpatient fusions for a long time now, and quite honestly, if it used to be if it's for ACDFs, disc arthroplasties, cervical, posterior lumbars, single level, sometimes 2 levels, I'd be open to it in my surgery center, and now bringing this in is it's really opened the door to more rigorous cases. So now, if you're a 1, 2, or 3 level lumbar surgery, lumbar fusion, if you're a posterior cervical, anterior cervical, I bring you there unless there's a comorbidity situation or an insurance reason that you have to go elsewhere on some contractual basis. It's the Medicare supports this. The Medicare coding system, CMS codes are being released regularly this year. The number of things we can do as surgeons in a surgery center are increasing and increasing and increasing. So it's here. This is a typical case of mine, and in this case, it's an L4-5 fusion, and what you can see here is on the left, the yellow is the part of the preoperative CT scan. I chose to do a block registration. Chose 6 points to register, did my flash navigation. So again, exposed subperiosteal dissection. And I think that's a part of what is getting my patients out of the surgery center the same day. Nobody stays overnight. I have, whether you're 70 years old or 45 years old, the truth is you're walking out of that surgery center that day. And I think a lot of that some of that has to do with I mentioned the subperiosteal dissection. I can't fail to think that meticulous exposure with the bovie, the deadening of what's going on in the area, doesn't play some role in that reduction in postoperative pain. But nonetheless, in this particular case, this is a very interesting case to me because you can see it's a single level fusion done by block registration. 70 seconds is what it took to register this. Again, no radiation, no fluoro whatsoever. I take a final after all the screws are placed, so a step aside and get a final. In this case, what happened was it's not too far away from L3, and it's not too far away from S1. And then it's the same incision, just about to get the 2-level or the 3-level fusion in there. So this has just sort of helped me become more confident in bringing more rigorous cases to the surgery center, and the accuracy has been absolutely wonderful. I mean, I haven't had a missed pedicle or a missed facet or anything that I've done there with this. And you're using your own skills in topography and understanding of the anatomy, combined with your new tool that just acts like a curette almost, and you're just a guided instrument that help you navigate around. I show this second case, this case here, only because it's a pretty straightforward case. It's a guy that had a pseudoarthrosis and an adjacent segment problem. And I wouldn't have otherwise brought him to the surgery center for not having the confidence and the ability to know how that I was going to get this done in a less invasive way, to do a 360 at the surgery center, again, go home that day. This was actually staged. He had the anterior done one day, and then he came back 2 weeks later and had the posterior done. And it's whether I wanted, in this case, I put in facet screws, but it could have been pedicle screws, whatever you're comfortable with doing. It's been wonderful. So for me, it's been a tremendous experience. I wish I could show you how to do this. I invite any and every one of you to come to Coeur d'Alene to see this. And any given Monday, we're doing 2 or 3 of these, whether it's lumbar or cervical. Thank you for having me here. And I'm going to show I put a little video in here of this. You're not going to hear what I'm saying, okay? But this is a cervical case, and I just want you to notice the room here. There's the opening. This is I don't know how many levels it would have been, but here's your posterior cervical incision. In this case, I chose normally for the lumbar, I might put the fiducial array down low, In this case, I might have done that, had it done low, done the registration, and figured out, okay, I'm putting in facet screws. I want the fiducial array up high. No big deal. I move it up high, boom, another registration. 30 seconds later, I'm back into business. There's the whole thing right there. You can see one rep in the background getting ready with the implants. There's no radiology tech or anything there. Quite efficient. Really, really, really great workflow. And the intelligence comes back to you, the surgeon. You get to dictate how you do this. So it's been great. Roland.
Is that fiducial array, is it on your head holder or what?
A spinous process.
On the spinous process?
Yeah, so what I might do in that one incision, what I might do to keep it out of the way is, actually that one lumbar incision, for example, I've come to doing a little stab and putting it through and grabbing a spinous process. It can be anywhere. In fact, I believe you'll have a iliac crest, kind of thing similar to what you're familiar with.
Can you do it on a head holder?
Jack?
Yes.
There you go. Yeah.
Great.
Mm-hmm. Good. Thank you. Thank you.
You love the simplicity?
I love the simplicity. It's simple.
I know. I tell you, I've been after this before it was FDA approved, and I was always transtubular. And I was like Jack and Bo, the company. Can I take the same picture through the tube? No, you need to have bigger. Then things moved on, and I just even seeing it and watching it, you think you're like, wow, how hard can you miss that? And everything. But you're so quick, to learn, and you have it, it really is so comforting that you're now in charge of this whole program. You're not, there's no Skyping to worry about, you just are, I do things now, like, let's say, I'm gonna put my upper screws in. I put my upper screws in, and I'll start the hole, the pilot hole, where I want the head to end up, and then aim it to where I want the trajectory of the screw to go. Now these guys happen to package up a pedicle screw system and head system that's on 2 trays with every kind of screw, whether it's cortical or regular, and whether it's a long head, short head, trauma head, whatever head, into 2 trays, which is really nice for the surgery center as well. It's been, when you're sensitive to the amount of trays you're running through autoclaves. But the navigation, the absence of radiation, thank you for that. It's great. All right.
This attracted me a great deal when it first came out, and I knew there was more development, and I appreciate the work that you do on this. I think it's really neat.
Yeah, it is.
It has legs. This is going to go somewhere. The simplicity is the beauty.
Yeah, I'll tell you, we have at the trauma hospital I work at. We have the robot there, and great. I was talking to Roland about it. He does the long deformity cases. I'll do thoracolumbar fractures with the robot, throwing maybe 12 screws per, and it's. But when you get into like for C1, C2, I didn't show the slide because I haven't done a C1, C2 at the surgery center, but to be able to pick your points for that bone trajectory sensitive case, and get away from a lot of the stuff you want to get away from. It's good in many applications. And whoever in this room adopts it and takes it, you're going to come up with new things to do because it's you're going to be your own maestro on this.